the most salient points, the things that you want to do for your exam. It'll probably take about 40 minutes for me to get through all these slides. Then I'm going to spend, we're going to have a 5-10 minute break. Then there's going to be about 15 minutes of me trying to talk to you about how to localize lesions, which I think is the most important thing for this year and basically up until if you don't become a neurologist or a neurosurgeon, basically the rest of your life, which is how to localize a lesion. So if people come in with certain symptoms, you want to know, oh, is it in the brain, is it in the spinal cord, is it in the brainstem, those sorts of things, where it is, and then also, given time frames, what sort of process might be involved. Is it a demyelinating process? Is it a vascular process, etc.? And then after that, I've got about 40 or 50 questions that we'll go through. I'm going to be a horrible person and pick you out, and I'm not going to be like other people that I know that have that things have happened to. That's not going to be what's going to happen, because my reason for doing it is basically, if I ask you a question and you don't know if you know the answer, that's fantastic, you teach everyone, fantastic. If you don't know the answer, then I want you to try and get there by first principles. Because if you're in an exam and you don't know the answer, you're not just going to write, oh, I don't know, or I'm going to ask the person next to me. You can't do that. So what you're going to do is you're going to have to get there by first principles, which means I know the sort of the physiology, I know a bit of the anatomy, and therefore I can work out the answer. And so you'll be able to do that if I call on you. Thirdly, if you really don't know it and you can't get there by first principles, I'll tell you the answer, and then you'll never forget it for the rest of your life because you'll feel really embarrassed that you didn't know it in front of everyone. So there you go. So it's a great system. And there's chocolates as well. And there's more chocolates in my bag somewhere. There. All right, cool. So, yeah, as I said, anatomy, embryology. So embryology, you don't really need to know all the stuff about sort of like, you learn in first year about the, ectoderm, mesoderm, endoderm, the ectoderm, that you get the notochord, and that causes the ectoderm, the overlying ectoderm, to cause the neural crests. They invaginate, you get a neural tube. That closes 27th, 29th days to form the caudal and cranial poles. Neural pores, sorry, and then they close, causing, and then if you don't, you always get anencephaly or spina bifida. You don't really need to know much about that. What I think is important is knowing the branchial arches and knowing some of the derivatives of those. So this is the branchial arch system, and that's what basically forms the face and everything involved. Here's a sort of here's a nice sort of view of how that, on the left-hand side, you can sort of see how those branchial arches sort of come together and form what is not a very attractive face there, in like that. So I think what's important to sort of realise is that, first of all, we have this system, and that system is based on the outside we've got ectoderm, the middle bits where that nerve, artery and vein is mesoderm, and on the inside is endoderm, yeah? And then the little curvatures on the outside, they're clefts, and on the inside they're pouches. So it's really just sort of nomenclature at this point. Then they form certain things. So here you'll see that the first branchial cleft forms the external acoustic meatus, so the outer ear. Then between that and the inner one is the tympanic membrane, and the tympanic membrane is quite interesting because it's actually made of 3 different types. It's actually got a layer of ectoderm, mesoderm, and endoderm within it. And then you've got the tympanic recess, or the mid-ear cavity. That was one of our questions, I believe, in our exam, talking about like what does the first arch, the first cleft and the first pouch form? It was something to do with that, I remember. The second one forms the second one calls the cervical sinus. And so what happens is, can you see that on the left-hand side of like the ectoderm part of the second arch usually comes and folds over, and you get and that sort of obliterates the sinus. If you don't, you get what that lady has, which is a cyst. So that's another sort of common question. What happens? A lady's got a lump here. It's cystic. It's fluctuant. What is it? It's a branchial cleft cyst. Know that what the second and third arches present. So the second arch will go to the body of the hyoid and the lesser cornu, and the greater cornu is third arch. Fourth arch is thyroid cartilage, and sixth arch is cricoid cartilage. fifth arch obviously goes away. Don't worry about the arteries. Just sort of worry, maybe learn the connective tissue and the nerves. The nerves are the most important thing. So the nerves, so the trigeminal nerve is the nerve of the first arch. The second arch is the facial nerve. The third arch is the glossopharyngeal nerve. Cool? Great. And then that's obviously a shark, which shows because humans are bony fish. If you go back into our phylogenicity, we're part of bony fish. So there you go. So the pouches are important. So the first pouch, as I said, forms the middle ear. The second one forms the fosses, which is like, you know, you've got the anterior and posterior pillars of the fauces that lie in the lateral part of the pharynx, and then between them is the tonsil, the tonsil where you get the palatine tonsil. Third arch is the thymus, and forms the inferior parathyroid. So there's a bit of a flip. Third arch forms inferior parathyroids. Fourth arch is superior parathyroids. I believe that was a question in our exam as well, talking about which one forms inferior parathyroids, or something to do with the fact that you needed to know the third arch was inferior and the fourth arch was superior parathyroids. And then the ultimobranchial body forms the C cells of the calcitonin, or the parafollicular cells of the thyroid. The face, don't worry about that. But do know that the first arch forms all of the face, and therefore that's the reason why you've got the fifth nerve, trigeminal nerve, supplying the innervation to the face. And also, I think it would be good to know that the nasolacrimal groove, which drains the tear ducts into which part of the nose for a chocolate? Inferior, yeah, good. Andrea's going to be getting a lot of chocolates, I think. Oh, sorry. All right, cool. Yeah, so it goes into the inferior recess. Okay, cool. So that's probably all you need to know from that. Anatomy. So there's the skull can be sort of broken down into what's called the calvarium, which is the top part of the skull, the neurocranium, which is the top part of the skull plus the base of the skull, which is, so the neurocranium encases the brain, and then the whole sort of skull has everything else involved as well. And, you know, depending on who you talk to, the mandible is or is not part of the skull. What's important is to, like, in terminology, anterior fossa is that blue bit, so everything above, everything anterior to the greater wing of sphenoid. The middle fossa is everything in that back thing. So if you think about the tentorium, or the tent, which is that green bit there. I'm going to call it the tent from now on just because I'm lazy. So the tent is that green thing which separates everything above it from everything below it. And below it is where the cerebellum and brainstem is. That's posterior fossa. While everything above it, including the occipital lobe, so everything that stands above the tent is still middle fossa. So don't just think that it's behind the sort of that area where the tent connects is called the petrous ridge. Don't think that just everything behind the petrous ridge is posterior fossa, because everything above it is still middle fossa. So the anterior fossa has a few different important parts. So anterior fossa is where basically the orbital part of the frontal lobe sits. So the frontal lobes sit on there. You've got a few different foramina. So you've got the foramen cecum, which lies anterior to the crista galli in the midline. It holds an emissary vein. It's nothing. Don't worry about it. What is sort of important is the cribriform plate and the crista galli. And so the crista galli and the frontal crest is where the falx sits, and the falx attaches along that line. And then the cribriform plate is where the little nerve roots of cranial nerve 1, what's it called? Olfactory. I don't know them by names. I just know them by number. So the olfactory nerve comes through. Exactly. And then they meet the olfactory bulb, and then it goes through the olfactory tracts, and then it goes through all the different parts to the rhinencephalon, the really old part of the brain, the phylogenetically connected part of the brain. So, and then below where the frontal lobes sit is the orbit. So that's sort of important. So in this area here is the orbit. And this is the apex of the orbit. And as we all know, the orbit is sort of divergent. Its apex is medially and it diverges laterally, and we'll go into that a bit later. Other sort of important things is what is this area here? This is not for a chocolate. So, Castle-Kirszbaum, good. So we've got the dorsum sellae, we've got the hypophyseal fossa, and we got the tuber hypophyseal. Is that right? Yeah. And then we've got, this is what? Anterior clinoid, posterior clinoid. We've got rotundum and ovale and spinosum. So these are very important things. So this is where V2, V3, and the middle meningeal come out. And then this is foramen lacerum, which is covered. Nothing goes through it. It's cartilage. The carotid goes over it. And depending on who you talk to, it's got a different thing. This is in a very lovely. So this is L. Roten. If you're interested in neurosurgery, he's like God. And this is sort of a really nice dissection of the anterior fossa. So what are these? What's this area in here? That's frontal sinus. Yeah, frontal sinus. This is olfactory bulb, olfactory tract. This is obviously optic nerve. This is internal carotid siphon coming through. This is PCOM, because posterior communicating. And you'll see that this is a sort of circular willows going around the pituitary here. Cool. So middle cranial fossa is basically everything else. So it's actually not as complicated as this, because this is all mostly posterior fossa, all these sort of lines. But middle fossa is basically where the temporal lobes sit on and the occipital lobes sit on. Tuberculum sellae, as I said, hypophyseal fossa and dorsum sellae form the Castle-Kirszbaum. You don't need to know much more than that. So what are some foramina that go through there? We've got the superior orbital fissure, which contains basically everything that goes into the orbit. So we've got V1, we've got the oculomotor nerves. So, sorry, the external ocular nerves, so the external ocular nerves, which include the oculomotor nerve, trochlear nerve, and abducens nerve, so 3, 4, and 6. Recurrent nerves and veins, you don't really need to know about that. Interestingly, if you want to get into it, there's actually quite an interesting embryological origin of the ophthalmic artery. There's dorsal and ventral sides. One comes from the inferior lateral trunk, one comes from A1, and then you can actually get different sort of patterns if you look at different people with neuroangiography, but sort of at this point. What is good to know is just you've got rotundum, ovale, and spinosum in that order, running from anterior to posterior. Rotundum basically has V2 in it. That's really all you need to know. V2 goes into the sphenopalatine fossa, which I'll talk about a bit later. It's around here. And then V2 obviously then goes through the orbit, but not through the superior orbital fissure, but through the inferior orbital fissure, through the orbit, in through the orbital canal, and then comes out here and supplies the cheek. That's why V2 is in the cheek area. Ovale has, if you remember it by ovale, as in O-V-A-L-E, so otic ganglion, which lies actually sort of outside of the foramen ovale bit in the actual infratemporal fossa. V3, which supplies obviously the sort of the mandibular area, but then also it's got motor nerves. It's the only of the trigeminal that contains motor nerves. The accessory meningeal artery, don't really worry about that. Lesser petrosal nerve, worry about that. I'm going to go through a bit more about autonomics a bit later. But, we're going to talk about lesser petrosal nerve, greater petrosal nerve, deep petrosal nerve, and how they all interact. And then foramen spinosum obviously just has the middle meningeal artery is all you really need to know about. It also has V3, a recurrent meningeal branch from V3. You can read the rest. So this is another really nice diagram from Roten, and it's got this is sort of so. What's this? This, and this is V1, V2, V3. This is the trigeminal Gasserian ganglion, depending on if you want to go eponymous or not. This is the semicircular canals. This is cochlea. This is what nerve? So that's facial nerve and superior and inferior vestibular nerves and cochlear nerve coming in there. This is the geniculate. This is the geniculate ganglion. This will then come out and to form the greater petrosal nerve. Yeah? And then we've got the quarter tympani as well. So this is sort of middle ear. What's this artery? For a chocolate. middle meningeal. Yeah? So this is spinosum. This is ovale and this is rotundum. Rotundum, ovale, spinosum. Yeah? So this is spinosum. And this is middle meningeal artery. So the dura actually sort of attaches along here such that the middle meningeal artery remains extradural. And then this is obviously cerebellar. This is superior petrosal sinus. You don't really need to worry about that. But I think what's sort of important with this sort of thing is when they want to test hard anatomy in the exams, they give you a photo. If it's easy anatomy, it's an easy question. And it's usually clinically based, and that's why I'm going to spend a bit of time looking at localization of lesions. After that, they might give you a hard question, and that'll be picture-based. They'll say, what is this, what is this? And after that, it's pretty simple. So you don't really need to know like all the little things. Like I don't expect them to ask you if that's the greater petrosal nerve, but I think it's fair game for them to ask you that that's the meningeal nerve, given that you know that this is V1, this is V2, sorry, and this is V3, and this is the next foramen across. So the posterior fossa is sort of quite complicated. You've got you've got the jugular foramen, you've got the internal acoustic meatus, you've got the hypoglossal canal and the foramen magnum. So foramen magnum, as I said, big. Obviously, the medulla turns into the spinal cord around there. You've got cranial nerve 11 coming up. So cranial nerve 11, the spinal part comes up through the foramen magnum, and then it goes out through the jugular foramen. Yeah? So it goes in through the foramen magnum, through the skull, and then out again. And that's the spinal part that'll join with the cranial part from the vagal nerve, the vagus nerve, sorry. Vertebral arteries come in through the foramen magnum. That's important because then they go on to form the basilar, which forms your posterior circulation. Anterior and posterior spinal arteries form around there and then go down and dive and supply a spinal cord. Internal acoustic meatus, what does it bring? It gives 7 and 8 to the middle ear. So 7 and 8 to the middle ear. You don't really need to know how it divides, but it does divide. There's something called the falciform ligament and Bill's bar, and it divides into 4 different nerves, which then supply the different areas that they need to supply. Don't worry about that. Just know it's 7 and 8. Jugular foramen is 9, 10, 11. Yeah? And also the jugular vein. So the jugular vein forms from the sigmoid sinus and the inferior petrosal sinus. That occurs sort of in the foramen, and then below that you've got the jugular bulb and you've got the internal jugular vein. So that's sort of important to know. So just know the main things. Know the cranial nerves and a big artery, or a big vein if it's in the foramen. Don't worry about the accessory meningeal artery or the the recurrent branch of the meningeal from V3 that goes through spinosum. Don't worry about those sort of things. Just worry about the main cranial nerve, which artery, and which major vessel as well. And hypoglossal is only 12, obviously. So this is a nice view of the posterior fossa. We've got superior peduncle, middle peduncle, inferior peduncle, cerebellar peduncles. This is the floor of the fourth. We've got Luschka here, and this is this is calamus scriptorius down here, which is where they all come together. These are spinal nerves. This is what area? So how many nerves are going through there? 1, 2, 3. Yeah? Where are they coming from? One is coming from the foramen magnum coming up and going through there. That could be accessory nerve. Whoa. This is coming from around the post-olivary sulcus. So this is probably 9. This is probably 10, sorry, and this is probably 9. This, coming down here, is coming from a bit lower. This is hypoglossal, yeah? So it sort of makes sense when you just look at it and go, okay, so this is spinal accessory, this is 10 and 9, and this is 12 going through here. Therefore, what's this? This has to be external. This has to be internal meatus, and therefore this is going to be 7 and 8 here. Yeah, cool. And then so this is vertebral. So vertebral artery comes around. This is posterior arch of C1, and they come together. And then behind here, you can see this is the left, and this is the right vertebrals, and they'll come together to form the basilar along here as well. What nerve is this? Up here. Come on, guys. Fourth nerve, yeah, because it's coming from the back. Fourth nerve is the only nerve that comes from the back. It comes from, these are the inferior colliculi. It comes from beneath there. Cool. And that's a nice little diagram as well. Brain. Cool. Don't worry about that. This is, again, all the different sulci and gyri of the brain. What is important is the fact that you've got frontal lobe, parietal lobe, temporal lobe, and occipital lobe. Just sort of learn that. Also know your locations of your major sort of Broca's area and Wernicke's area. So Broca's area is in here. It is the pars triangularis and pars opercularis of the inferior frontal gyrus. This is the pars orbitalis. It is not part of it. These are the opercular. This is the Sylvian fissure, or the lateral fissure. You'll never hear the word lateral fissure ever be used, ever. It's always Sylvian fissure, even though, like, we're trying to get rid of eponymous names in medicine. That's the Sylvian fissure. This is the central sulcus, or Orlandic sulcus. And then, obviously, you've got your motor in front of it and your sensory behind it in the pre- and post-central gyri, which is, I believe, Brodmann 4 and Brodmann 1, 2, 3. Yeah, so then we've got supramarginal gyrus here. This is where Wernicke's area is. So if you're going to remember anything, remember Wernicke's is supramarginal and pars triangularis opercularis is Broca's. If you're not going to remember pars opercularis triangularis, remember inferior frontal gyrus, yeah, which is this whole thing here. Inferior frontal gyrus is Broca, supramarginal is Wernicke. In there and sort of parts of the and the posterior part of the superior temporal gyrus is also a bit of Wernicke. In here is called the Unsnip fasciculus, and there's also some what's the word? There's some we'll go through when we talk over speech, but there's parts that go through, and you can get conductive aphasias as well. On the medial side, know this sort of well. Like, know that this is the what's this area? This big white thing. Corpus Callosum. Good. Yay, now we know. Good. So this is the Corpus Callosum. This is genu. This is splenium. This is rostrum. This is body. So rostrum's down here. It goes into genu, goes into body, goes into splenium. This is the fornix, as it says. And then we've got the pineal gland. Up here, in between the splenium and the pineal gland, is the habenular commissure. Below that, this area here is the posterior commissure. This is anterior commissure. This is interthalamic adhesion, or massa intermedia. In this area here is what? Hypothalamus, yeah? In this area here is thalamus. Cool? So thalamus and hypothalamus line the third ventricle, and the fourth ventricle is, sorry, the lateral ventricle is between the, is lined above by the corpus, below by the fornix, medially by the septum pellucidum, which is this area that lies between the body and the fornix, and laterally by the caudate, the head of the caudate, and different things as it transfers across. It's quite a large ventricle. So I think that's probably all you need to know. This is important. Know this. If you don't know this, you know, let's be honest. Frontal lobe. So frontal lobe has some important parts. We've got the frontal eye field, prefrontal area, and Broca's area. So Broca's is still frontal lobe, obviously. Frontal eye field, supplementary motor area. So SMA, PMA, and M1. M1 lies anterior to the central sulcus in Brodmann area 4. SMA and PMA are a bit more anterior to that, and the frontal eye field is a little bit anterior to that. Prefrontal area is where your executive functioning is. So if someone's acting weirdly or has what's called a frontal release syndrome, which is where they might be hyperphagic, hypersexual, sort of continue to like spend a lot of money on different things, just be what's it called? Yeah, have lots of impulses and fulfill them and continue with them. That's called frontal release, and that's a sign that you've got a problem with your frontal lobe. It's also seen in psychiatric conditions because you've got that sort of dopaminergic mesocortical pathway that releases this area as well. So M1, know the homunculus. Like, this is your bread and butter, okay? So the medial side of the homunculus that lies within the interhemispheric fissure has the legs, lower limb. Then we go all the way across to we're sort of in the, so we're sort of in this middle area, and we've got arms, and then we've got face, yeah? And there's actually some really interesting sort of, and things that where if you have migraines, for example, and migraines are caused by what's called spreading cortical depolarization, like spreading of Liao, it's called, is the guy who discovered it. And what can actually happen is you get what's called a Jacksonian march, which is where your hands start moving and you get spasms or movement of your hands going up your body. And that's actually caused by depolarization running up this gyrus and causing the different neurons to be done. And so it'll take longer to go through your hand than it will through here, because the hand is more, there's more neurons in the hand, and the hand has got a larger surface area over the thing. So a Jacksonian march will spend a lot of time in the hands, not much time here, but then a bit of time in the face, because the face obviously has a lot of neurons and is well shown on that gyrus. So motor cortex, where does motor cortex go? The neurons go from there. They then go into the internal capsule. Which part of the internal capsule? Posterior limb, very good. Posterior limb of the internal capsule, then through the cerebral peduncles, and then in through the midbrain, through the brainstem, and then down to the corticospinal tract. They decussate in the inferior part of the medulla at the pyramids. Cool. M2, I think this is something that, it's, as I wrote there, it's crap, but they'll test you on it. So know the supplementary motor area, know the premotor area, and know that one's for whatever I've written there. One's for planning of motor actions, and one's for guided movements. Parietal lobe, know it's got S1, know it's got the sensory cortex. You can get neglect. So if you have a right parietal lesion, you'll have a left neglect, and you might not see things on the left. You might only draw half a clock face, or draw all your numbers of your clock face on one half. That's sort of important. You've also got Wernicke's area and the supramarginal gyrus, as well as the uncinate fasciculus, which will cause your conductive aphasias as well. That's really all you need to know. It's not that impressive. Again, it's a very similar distribution. Of course, you've got slightly different percentages and of different areas, but the whole sort of idea is the same, that you've got lower limb on the medial side, it then curves across the convexity of the parietal lobe, and you've got arms, face as well. Temporal lobe has Wernicke's area, parts of it as well. You've got primary auditory complex on the pars temporalis, or the planum temporalis, sorry. Hippocampus, uncus, so memory. Memory is important, and seizures often present there. This is a better slide because I did it. That's not true, but it doesn't mean it's better. But I did this, and this is actually from my notes from last year. And it's I found it a very easy way of sort of working out where everything is and how it does. So this is taken from one of their lectures, I think, and I just added things on top of it. So Wernicke's area is a sensory aphasia. So the replicating words is that, arcuate fasciculus. I've been saying uncinate fasciculus. Arcuate fasciculus. Uncinate fasciculus lies at the start of the insula, the limb and insula. Don't worry about that. Okay, arcuate fasciculus. My mistake. So arcuate fasciculus lies between the Broca's and Wernicke's area. And so if you don't have that, you can't repeat words. Yeah? And if you've got anything before that, so in that pathway, if you've got anything before that, you also can't repeat words. So before that is Wernicke's area here. So if you don't have Wernicke's area, you can't repeat and you can't speak. So you get a sense, well, you can speak, but it's gibberish. Yeah, it's gibberish. So you get a Wernicke's aphasia, or a sensory aphasia. So you can't understand what's going on, but you can speak fluently, but you just won't make any sense. If you get a transcortical sensory aphasia, you've still got this here, because this is a different pathway. So you'll still be able to repeat something. So someone will say to you, repeat something, you'll be able to do it perfectly. But you won't sort of understand things that will be spoken to you, and you won't be able to do commands, etc., because you won't understand what's being said. Transcortical motor aphasia is exactly the opposite. You understand things. It's hard for you to say things, but you can repeat. So it's hard for you to say things spontaneously. It's hard for you to say things in conversation, but it's very easy for you to repeat things. And a lot of these people just repeat everything they say. It's called echolalia. And then you've also got a Broca's aphasia, which is an expressive aphasia, which is where you just can't speak. Cool? Done. Aphasia. So I would learn that your numbers for this. No one uses Brodmann numbers in clinical medicine, but you should know it just for your exams. Know that Broca's aphasia, so pars opercularis and triangularis, are 44, 45, and Wernicke's is 22. And then conduction aphasia, that's the arcuate fasciculus what have I, not the unsnapped fasciculus like I've been saying, I apologize again. Yeah, arcuate fasciculus, conductive aphasia. That's probably all you need. Don't worry. I wouldn't worry too much about the transcortical ones at this stage. Occipital lobe has V1. That's the only thing you need to know about it. Has the sensory part of V1 is visual cortex. So homonymous, I'll talk about the visual system later. Ventricles. So the big things in blue are your lateral ventricles. This is front. You don't need to know, but this is frontal horn, body, atrium, occipital horn, and temporal horn. This is what? What are these two light blue things? Cyan things. Sorry? Intraventricular foramina. Cool. Yeah? Of whom? Monroe. Good. Okay. This is third ventricle. This is a very large interthalamic adhesion, which shouldn't really be there. This is suprachiasmatic recess, that first of those top things, and underneath that is infundibular recess. So that lies in the sort of the pituitary stalk. Yeah? What's the red thing? Supraduct duct of? Sylvius. Good. This is fourth ventricle. Yeah? What are the two things coming out the side? Luschka. Yeah, lateral recesses. Yeah? And this one is Magendie. And then this is canal that goes into the spinal canal. That's all you need to know. Don't worry about all the different relations that I got there on the bottom. That was a bit overboard. Papilloedema. We had a question about that. It's always papilloedema. Papilloedema is... So when you look at the second nerve, it actually carries the dura. So the epineurium of the nerve is dura. It's dura-lined. And so if you've got dura, underneath the dura, you've got a subdural space or a subarachnoid space. And therefore, that's continuous to the subarachnoid space of the brain. So if you have intracranial hypertension, that causes increase in your pressure in the side of the brain, and that'll be transmitted through the sheath of the nerve into the back of the eye, and that causes... So usually there's a bit of cupping. There's a slight bit of cupping where the nerves come in and it sort of evaginates at the back of the eye, and that is lost in papilloedema, and you get this sort of loss of sort of a nice sort of circle around the nerve. Basal nuclei, deep structures. So what's important, what's not important? In my mind, I'd say for your exams, what's important is sort of not knowing individual bits, just knowing internal capsule, knowing a bit about the basal ganglia, knowing about thalamus, knowing about substantia nigra, not knowing about pars compacta, pars reticularis. That's unimportant, except that compacta is where Parkinson's mostly occurs. It's not reticularis, it's mostly compacta. Cool. So I think this is a good diagram to sort of know, or something similar to this, where you've got a cross-section of the brain at this level. So obviously we've got frontal lobe, temporal lobe. Here is, what's this cortex called? Insula. Good. Then this is extreme capsule. This is what? Claustrum. What's this? External capsule. What's this? Putamen. Good. This is globus pallidus. This is caudate. This is so together the putamen and the caudate are called the striatum, and that's because of these things, which look like lines or striae across it. Then between these two forms the internal capsule. This is obviously corpus. Then you've got lateral ventricle and third ventricle as well. Cool. That's all you need to know. I think if you know that, you're doing good. This is sort of other basal structures. So this is what I was talking about. This is what I was talking about, the striatum. So you've got putamen, caudate, and between them the lines that form striatum. At the end of the caudate, you've got the amygdala, which is Craig Cass's favourite area. We've got nucleus accumbens here, which is the anterior bit here. Don't worry about that. So striatum, this is a nice diagram to show where the sort of internal capsule goes. It goes in between these two, in between thalamus and the lentiform nucleus. And lentiform nucleus is another name for putamen and globus pallidus put together. Nigrostriatal pathway. So I think what would be important to know, and people got really shitty at the end of our exam, saying like, oh, they got the question wrong, D1, D2, neurons, etc., etc. It was right, just people didn't know it. The question was correct. So I think it's important that you do sort of know it. So there's two pathways. Well, there's lots of pathways, but there's two pathways that you need to know about. which are the direct and indirect pathway. Direct pathway is facilitatory of the cortex. Direct is facilitatory, which means that if you go through your direct pathway, you're going to do that motion. Yeah? So your cortex goes, am I going to do this motion? It goes through the direct pathway. It goes, yes, I'm going to do that motion. Great. Indirect pathway is inhibitory. It goes, oh, am I going to do this pathway? It goes through the basal ganglia. It goes, no, I'm not going to do this pathway. I'm not going to do this movement, sorry. And that's inhibitory. So direct is facilitatory. Indirect is inhibitory. In, easy to understand. Inhibitory, indirect. Now, the dopaminergic pathway, or the nigrostriatal pathway of the substantia nigra to the globus pallidus is facilitatory of the direct pathway and inhibits the indirect pathway. So if you think about that, that's going to always, in both cases, want to make you do that movement, yeah? Because we're facilitating the one that facilitates. We're going yes to the direct, and we're inhibiting the one that is indirect, or the one that is inhibitory. So if we're inhibiting an inhibitory pathway, that's another way of facilitating. So anything that dopamine does to the basal ganglia is always facilitatory of the cortex. It just does it by two different mechanisms. Does that make sense? Because that's the sort of important thing. Does everyone get that? Cool. Now, D1 neurons are positive and D2 are negative. So D1 neurons, this is easy. D1 is direct. D2 is indirect. You can just remember 1 and 2, direct, indirect, yeah? So D1 neurons are facilitatory of the direct, and D2 neurons are inhibitory of the indirect. And D just means dopamine. So dopamine receptor 1, dopamine receptor 2. Cool? Everyone get that? Because that's a thing that you'll lose a mark or two on the exam if you don't, well, you might, probably not. But if they ask that sort of question, you could lose that mark if you don't understand it. Cool? And you could complain to the faculty for no reason. The next, so that's all of what I said. This is a nice little schematic that I drew, which is really shitty, but you'll understand that it's the same sort of thing. We're adding an extra step. So we're inhibiting this, so the blue is obviously inhibitory, so D2 is inhibiting the striatum, while D1 is facilitating. D1 is facilitating the direct, which facilitates the cortex. D2 is inhibiting the inhibitory pathway, and therefore facilitating the cortex again. So, and that makes sense, because if you think about Parkinsonism and Parkinson's disease, well, Parkinson's disease, not Parkinsonism. If you think about Parkinson's disease and the phenotype of Parkinsonism, you see that these people are not moving very well. It's because they don't have a lot of dopamine. And so therefore, they're not facilitating anything. So their movements are slow and bradykinesic. Yeah? Cool. So Parkinson's disease, which one's normal, which one's abnormal? Okay, I should have asked that a bit better because I'm getting left and right for which ones. So the left is normal, right is abnormal, because we've got that substantia nigra has still got its pigment, and so therefore it's still present. Don't worry about this. That's Huntington's disease, which is an interesting condition. Hemibolism, another interesting condition. Actually, I think you should know that hemibolism is part of the subthalamic nucleus. So an infarct of the subthalamic nucleus causes hemibolism. That took you maybe 5 seconds to remember, and you're not going to lose any. It's not kicking out something important. It's one-liner, and it could be a question. So hemibolism is subthalamic nucleus. Yeah. Don't worry about. Does anyone know what any of these are, just out of curiosity? Any interested neurologists? Okay, sorry. Multiple systems atrophy, pantothenate kinase associated neurodegeneration, progressive nuclear palsy. No? Okay, good. So thalamus, don't worry about it. All you need to know, guys, sorry. All you need to know about thalamus is that it has different parts. Some of them are motor, some of them are sensory. So everything apart from which sense goes through the thalamus. Smell. Smell. Why doesn't smell go through? Why doesn't smell go through? Can someone actually say it? There's a chocolate. There's a chocolate. Come on. Smell. No. Well done. Now the question was, why doesn't smell go through there? Why doesn't? Okay. So smell doesn't go through there because it's the oldest sense. So of all, someone knew that, so that's good. It's the oldest sense. So there's no. So it was done like in fishes, in things before that, And so so it doesn't actually need to go through the thalamus because the thalamus and the neocortex are all newer sort of things. So I think it's sort of, what would be good to know is that as well as having strokes in the internal capsule that can cause pure motor and pure sensory things, which I'll go on to in a second, you can also get things in the thalamus that cause pure motor and pure sensory. Now, notice I'm taking a lot of time. So, again, you don't really need to worry about these. This is a nice picture of the brain. This is the corpus, so you don't need to know anything about that. This is the corpus again. It's a nice picture. This is a very nice picture. This is the fornix. The fornix is something, I think you should just know it just because you don't need to know it for its functional purpose, but you should know it for its anatomical purpose in the fact that it is the border of the, it is the top of the third ventricle and the bottom of the lateral, of the bodies of the lateral ventricle, and also forms the medial parts of the intraventricular foramina of Monro. Yeah? So on the intraventricular foramina of Monro, there's columns of fornix in the middle, and there's actually genu of internal capsule on the lateral side. Know that it can, maybe actually do know that it connects hippocampus and dentate gyrus to mammillary bodies. That's probably all you need to know. Anyone know what the space in between these two are called? This is for like 2 chocolates. No. So in between the two, so septum pellucidum is between the genu and the fornix. Between the two bodies of the fornix is something called the velum interpositum, and in the velum interpositum is the internal cerebral veins and the medial posterior choroidal arteries. Why isn't that going forward? That's going forward. Okay, this is another picture of fornix. It's pretty. This is pretty. This is pretty as well. Okay, anterior commissure and posterior commissure. Know that when you point here, this is posterior commissure. It is below the epithalamus. It is below the pineal gland. Epithalamus is another name for pineal gland. Is below the epithalamus. This is superior colliculus, inferior colliculus. In here, there's another sort of thing. This is the habenular commissure. Don't worry about it, but just know it isn't posterior commissure. Anterior commissure is obviously here. Whoa, what happened there? We're going through, whoa. Okay, can I escape this? We've gone to like 200, we've gone a few slides forward. Oh shit. I've just broken it. I feel like one of those old lecturers that doesn't know how to use technology. With someone that's young and knows how to know fix it.
How'd you turn that on?
I don't know.
Okay, we'll just like get rid of it. Get rid of it. So, okay, it's gone. Do you remember which slide you want?
I'll be able to go through it. I'll go through on the side and this. And we're back. Guys. Come. Internal capsule, know that we've got posterior limb, anterior limb. Anterior limb is frontopontine fibres. Doesn't it, like, you don't need to know what it does. You don't need to know what it does. Know that the genu here, so in here is like lateral ventricle, foramina of Monro, this area here. This is genu. What's in genu? What fibres? Corticobulba, it says it. What does corticobulba do? Innervate the face, yeah? It's the cranial nerve fibres. That's important. So know that if you're going to attack, if you lose the genu, you lose your corticobulbar fibres, which are your cranial nerve fibres. Anything posterior to that is both sensory, so all your sensory fibres from the rest of your body and all your motor fibres from the rest of your body all go through posterior limb of internal capsule. And if you want to be a wanker, you can say that the sublenticular and retrolenticular parts are the auditory and optic radiations, respectively. Brainstem. This is a nice picture of the brainstem. This is another nice picture of the brainstem. Okay, I think if you can label this, that would be good. Yeah, in an exam, that's a sort of question they could ask. You know, they'll point at something. What's this nerve? They'll point at something. What's this? You know. So these are the pyramids. Yeah. What's this sulcus called? preolivary. If that's the preolivary sulcus, what's this? The olive. Yeah, good. Postolivary sulcus. Good. So from the preolivary sulcus, we get what cranial nerve? We get cranial nerve 12. From the postolivary sulcus, we get 10. We get 9 and 10, sorry. And then 8 from here. Now, from the pontomedullary junction, sorry, 9. We get from the pontomedullary junction, we get 7 and 8. Around here is Luschka. This is foramen cecum. You don't need to know about that, I don't think. This is sixth nerve. This is pons. This is the sort of sulcus where the basilar artery sits. Yeah. This is flocculus. And this is cerebellum. This is brain, or cerebrum. These are the optic tracts going into the chiasm, going into the nerves. This is the stalk of the pituitary, mammillary bodies. This is the interpeduncular fossa. This is third nerve, and this is fourth nerve coming from the back, fifth nerve coming from the side of the pons. Everyone get that? That's something, I think, if you label that, you're doing well. That's good. This is the decussation of the pyramids. Anyone know what this space, this is for a chocolate. Anyone know what this space is called?
Smell.
One day it'll be right. One day it'll be right. Anyone? Anyone? Okay, it's called the anterior perforated substance, yeah? And this is where all your you laugh and you go, who needs to know that? It's actually important. This is where basically so internal capsule, basal ganglia all get perfused through this area, okay? So if you knock out anything in there, and if you're a neurosurgeon and you knock that out, you've basically killed them. So don't do that. Okay, most important thing about what I'm probably most important thing I'm going to teach you today is the rule of fours, yeah? So rule of fours is based on the fact that we have four cranial nerves above the pons, 4 in the pons, and 4 in the medulla, yeah? I'm sure you're all familiar with the rule of fours. So optic tract, optic nerves, and cranial nerve 1, olfactory, that's it, are above the pons, as is 3 and 4, yeah? 5, 6, 7, and 8 are all in the pons, and 9, 10, 11, 12 are medulla. Cool. So the next sort of thing we need to go are they medial or are they lateral? Because that's going to influence which artery is perfusing them, and therefore if you have a stroke of a certain artery, what's going to happen. So medial are the cranial nerves 3, 4, 6, and 12. Notice that they're all fractions of 12, or factors of 12. 3, 4, 6, and 12. Not 1, unfortunately. But 3, 4, 6, and 12, which is a fact. So cranial nerve 3, cranial nerve 4, cranial nerve 6, and cranial nerve 12. Now, for a chocolate, who can tell me why it's those nerves that are medial and not 5 and 7?
Because we're only motor.
Sorry?
The only one very motor, and the motor part...
Isn't V3 motor?
Yeah, but...
Why is that lateral?
Because there's some other vision.
Yeah, that's the important thing. Okay, so the important thing about it is that they're from... So the ones that are on the lateral, so 7 and 5 and V3 are lateral because they are from special visceral afferents. They come from the nerves from the branchial arches, yeah? So 5, 7, and 9 are all lateral, and they're the first, second, and third branchial arches. The medial ones, 3, 4, 6, and 12, come from somites, occipital somites, which are skeletal muscle, not muscle from the, not special muscle. You know, it's skeletal muscle, and therefore they come from the midline, yeah? That's important. And then so 3, 4, 6, and 12 are in the middle, yeah? Therefore, the lateral ones are all the other cranial nerves, correct? Cool. So now we've separated the cranial nerves from pons, medulla, midbrain, and above, and we've gone medial and lateral. Does everyone get that so far? Yeah. Good. The next thing we need to do is look at tracts. So there are some long tracts that run through. What are some tracts that run through the brainstem? Corticospinal. What doesn't run through? Smell. Thank you. Come on. Keep up. Okay. So, So we've got corticospinal, VCML, spinothalamic, spinocerebellar, those sorts of things. Yeah. So the medial ones, very sort of helpfully, have M in them. So the motor, the DCML, the medial longitudinal fasciculus, and the motor nuclei, as I've already said, of 3, 4, 6, and 12, or 4Ms, they all run in the midline. So motor nucleus of 3, 4, 6, and 12 in the midline. The DCML, so which is your like light touch discriminative sensation, that runs in the midline. Your medial longitudinal fasciculus, which I'll talk about later, midline, and also motor is also midline. The lateral ones all have S in them. So the spinothalamic, spinocerebellar, the SNS, so the sympathetic, and the spinal nucleus of the fifth nerve, which supplies the majority of the sort of sensation to the pharynx and face. Yeah? Cool. So they're all the ones that are lateral. And so when we think of something, so let's say we've got a, what's the question that, what's the stroke syndrome that everyone likes talking about? Wallenberg, good, which is a what stroke? What artery? Pica, yeah, good. Posterior inferior cerebellar. So if we think about that, what does the pica perfuse? So we're looking at it here. The pica perfuses the lateral medulla, yeah? So these are the lateral ones, these are the medial ones. This is the lateral medulla. So if we've got a lateral medullary syndrome, yeah? What's in the lateral medulla? So we're in the medulla, so we're in the last 4 cranial nerves. So we're talking about 9, 10, 11, 12, yeah? Good, I can't count. 9, 10, 11, 12. Now, which ones of those are lateral? 9, 10, and 11, yeah? Because they're the ones that aren't 3, 4, 6, and 12. Now, so we know we're talking about 9, 10, 11 are the ones that are going to be affected. Next, what else are we talking about? We're talking about what tracks are laterally. Spinal nucleus of fifth, so you're going to lose sensation to the face. Yeah? What else? SNS. We know that we lose our sympathetics on that side of the body with the Wallenberg syndrome. That's on the lateral side. What else have we got? Spinothalamic and spinocerebellar. We know that we lose spinothalamic, we lose pain on that side of the body because, or the other side of the body, because we've got a spinothalamic lesion, yeah? Cool. So you can sort of work it out. Once you know what's lateral, what's medial, the 4S's are lateral, the 4M's are medial, and which cranial nerves are there. If someone says you've got a medial pontine lesion, you know what it's going to be, yeah? It's going to be the 6th nerve, and it's going to be DCML, it's going to be motor cortex, it's going to be all those things that we talked about. And so that is a question they sort of gave in the exam. I think they gave us a sort of constellation of symptoms, and they said, where's the lesion? And there was like medial medulla, lateral medulla, medial pons, lateral pons, all those sorts of things. I believe it was lateral pons was the answer, but it's that sort of thing. Yeah? So the types of fibres, this is semi-important to know. I think what is sort of nice is if, now for the people playing along at home, they can't see this, but if you think about the way the neural tube forms, it forms like this, yeah? It's a tube. And so you've got a basal plate and alar plate. And then what happens is, in the spinal cord and in the brainstem, it spreads out like this. Yeah? So you know in the spinal cord, the anterior part, which I'll say is my thumbs, the anterior part is motor, and the posterior part is sensory, yeah? Everyone remember that from the spinal cord? Now, if that's the same in the brain and in the brainstem, but what happens is they spread open like this. So in the brainstem and in the brainstem, the medial parts are motor, and the lateral parts are sensory, yeah? And that's why when you look at all these different diagrams and you see, like in this fantastic diagram, you see that this is the sulcus limitans, and the sulcus limitans is that definition between the alar plate and the basal plate. You can see that when it opens up, all the medial bits are the motor ones because they stay where they were, and then as we spread open like this, the lateral things, which are over my fingers, are the sensory ones. Does that make sense? Sort of? Yeah. That's really... So then you sort of know what's going on. These all make sense if you think about that rule of force that I was talking about. That we've got medial ones are 3, 4, 6, and 12, which are these red things, general somatic efference. Yeah? So general somatic efference, so like normal muscle, skeletal muscle. General viscera efference, so your autonomic efference. Special ones, which are those special muscles that come from the branchial clefts, the branchial arches, sorry. And then we've got our special visceral afference, general visceral afference, so they're like autonomic sensory. Special sensory afference, so like your vestibular function, your hearing, etc. And general somatic efference, which is like your normal touch, which includes the spinal nucleus of fifth nerve. Cool? Cool. Olfactory nerve, you know what it does. in the slides, I've got a lot about the physiology. I don't want to go through the physiology right now, but in the slides, they've got it. Maybe 3 or 4 questions each year on the physiology. So like knowing these sorts of things, knowing mitral. I don't know if you have access to it. I'm sure you do. There's a online thing. There's like, if you go, I can't remember what it's called, but like if the guy that does the lectures for these, I think he put on something online about like, there's lots of questions online. Do those questions, because half the time they're in the exam. Yeah? So do those questions. Olfaction. So know the nasal region a bit. Know the arterial supply. So this area here is where you get lots of nosebleeds, called Kisselbach's area, or Kisselbach's area, and it's the anastomosis of the posterior anterior ethmoidals, the sphenopalatine, which is also known as the artery of epistaxis, because it's the most likely to bleed, and when it does bleed, it bleeds like a bugger. Greater palatine, and then the incisive branch of the facial, the superior labial branch, sorry, of the facial, the septal branch of the facial artery. So this is Kisselbach's area. Does anyone know the name of the area back here that's also a plexus for bleeding? For a chocolate. That's silence. Woodruff's plexus is the name for the other one. Okay, cool. So what's important? If you've all heard of that triangle, like the bad triangle, don't pop your pimples in that area or whatever. So that's because the inferior ophthalmic vein drains that area. And the inferior ophthalmic vein goes through the orbit, back into the eye, back into the cavernous sinus. And so that is a normal connection between the outer part of your body and the cavernous sinus. And if you think about it, you don't want bacteria in your cavernous sinus. Yeah, you get a cavernous sinus syndrome, not fun. So don't pop your pimples in that area. Innervation. Innervation's quite easy. It's just if you draw a line from the septum to the back of the nose, it's on top of its V1, below its V2. Yeah? Just that diagram there, that's fine. Paranasal sinuses, don't worry about them. Optic nerve, pretty. Don't worry about that. Optic pathway, don't worry about that. Know that the superior part, so superior visual field, so top part of my vision, goes to the bottom of my retina. Bottom of my retina stays the bottom. It goes through, what's this area? What's this thing? Good, LGN, yeah, good. So it goes through the LGN, goes around this area here. Anyone know what that thing's called? Meyer's loop, good. Goes around the temporal horn and then through into V1. So the inferior part of V1 and the inferior optic radiation is all superior visual field and et cetera, vice versa, I should say. Now, this travels in which lobe? Parietal. This travels in temporal lobe. So if you have a temporal lobe problem, you're going to have a superior quadrantinopia. Yeah? If you have a parietal lobe problem, you're going to have an inferior quadrantinopia. Cool. This is a nice picture of a dissection of the optic radiations going into V1. This is another nice thing. So temporal visual field goes into medial part. The medial parts of the retina, or the temporal visual fields, are the things that decussate, yeah? And if we have something growing in here, such as an adenoma or a craniopharyngioma, for any of those that like their Rathke's pouch tumours, different to a Rathke's pouch cyst as well, you can get quadrantinopias or the classical Monash bitemporal hemianopia, yeah? There's a lot of classical Monash things that happen a lot in real life, don't happen a lot in real life. Bitemporal hemianopia is something that actually happens. Good. And you get that issue. So bitemporal hemianopia is an optic chiasm problem. Anything anterior to the chiasm is going to be an eye problem. You're going to lose vision in one eye, which means you're going to have both both nasal and temporal problems of that eye. So you're going to lose both left and right vision. Yeah? If it's after the chiasm, it's one side of your vision. So it's not one eye, it's one side of your vision. So you'll have all your vision of your left-hand side, all your vision of your right-hand side if it's after the chiasm. If it's before the chiasm, then it's both sides but one eye. Does that sort of make sense? Good. Ocular motor, what does it supply? Everything but what? But superior oblique and what? and lateral rectus, good, which are 4th and 6th respectively. Also note that we've got the Edinger-Westphal nucleus. Edinger-Westphal nucleus is PSNS or SNS? PSNS, good. So every single, where does the SNS come from for your brain and your spinal cord? Yeah, it comes from the cervical plexus. So it goes down through the lateral part of the brainstem, as we said, because it's an S, it's a lateral brainstem tract, and then goes to the stellate ganglion, and then goes up through your thing, how does it actually get to the brain, though? How does it get inside the cranium? Sorry? Yeah? So it goes through the blood vessels. Specifically, it goes around the internal carotid artery. It's the internal carotid plexus. Yeah? That's how it gets into the cranium. The rest of them, if you're going facial nerve or other things, facial artery, middle meningeal artery, as I'll talk about later, carry different things as well. So, importantly, if you've got a third nerve palsy, you're going to have, is your eye going to be small or big? Okay, this is the sort of question, because I didn't get it straight away. I want first principles, yeah? So first principles, it carries, if you're third nerve palsy, SNS or PSNS gone? PSNS, good. PSNS dilates or constricts the eye? Go on, guys. It constricts the eye, good. It constricts. So sympathetics dilate, because you want to see bigger when you're running away from your bear or whatever, and it constricts when you want SNS, yeah? So we're going to have SNS predominant, and therefore we're going to have a big eye. Yeah, so you have a blown pupil. Yeah, a down and out and blown pupil means you've got a third nerve palsy, and it's not good. Does anyone know when you can get only pure motor third nerve, or only SNS PSNS pure third nerve palsies for a chocolate? Gosh, I'm going to have lots of chocolate at the end. This is going to be great. Come on, guys. Okay, so the SNS and the PSNS of the third nerve run on the outside, and the motor lies in the middle. So if you've got a ischemic problem, if you think about the arteries come from the outside, yeah? So the arteries coming from the outside means that if the SNS is also on the outside, that's going to be better perfused than the things that are further away from where the arteries are, which is the middle. The middle is worse perfused. So if you have an ischemic problem, such as diabetes, where you get microvascular complications, you're going to have a more motor problem. Conversely, if you have a trauma, such as an aneurysm, you're more likely going to have, or you have pressure from hydrocephalus, for example, you're more likely going to have a larger pupil because the SNS are on the outside and more susceptible to trauma. This is a nice picture. This is a very nice picture of dissection, I should say, of so this is what area? Clivus. Yeah? This is clivus. This is dorsum cellae, hypophyseal fossa. This is internal carotid. This is one of the superior hypophyseal arteries. This is second nerve, third nerve. This is anterior clinoid. This is fifth nerve. This is sixth nerve going under which ligament? Gruber's ligament, petrosphenoidal ligament. Cool. Fourth nerve swaps, yeah? So the nucleus is on the opposite side to the nerve. It comes from the back. It's the only nerve to come from the back. It comes from below the inferior colliculus. It supplies the superior oblique. Now, because a lot of the questions that you get in your exams are all clinical, yeah? So how would someone with a fourth nerve present? Head tilt, yeah, because what does the superior oblique do? It intorts. So you're going to want to purposely intort your body to compensate for that, yeah?
Do you tilt to the side of the lesion or the other side? Which side do you tilt towards?
Which side do we tilt towards? Away? There it is. Cool? There's a nice diagram. Cool. Abducens nerve does lateral rectus does abduction of the eye, abduction of the eye. This is a really nice dissection. This is basilar artery. This is looking from anterior, so we've gotten rid of the sort of base of skull. This is pons. This is sixth nerve coming from down here up through Dorello's canal into the cavernous sinus and up. This is, can you see I was talking about that carotid plexus that carries the SNS? This is all around the carotid here. importantly, note how long this nerve is. Yeah, this nerve's quite long. It's going all the way up here into the orbit. So if you've got intracranial hypertension, it pulls on that nerve. So a sixth nerve palsy is likely. Yeah, as is a third nerve palsy because you have the uncus of the temporal lobe pushing against it. This is a nice diagram of the that we sort of showed earlier with the carotid greater petrosal nerve. This is a nice picture of the extraocular nerves. So third nerve, fourth nerve, and sixth nerve coming from here. Internuclear ophthalmoplegia, don't worry about it. Know this, okay? It was a question in our exam. What is the paramedian pontine reticular formation? Paramedian pontine reticular formation, or PPRF, is the start of your lateral abduction of the eye. It's where the abduction starts, yeah? So you go here, this starts, it goes then to your right lateral rectus, and it looks left. Now, if you think about it, if I'm looking left or right, one eye's got to use lateral rectus, one eye's got to use medial rectus. But they're different nuclei, so there's got to be some connection between those two, and that's the medial longitudinal fasciculus. And so that lies from the abducens nuclei at 6, goes all the way up to third, and then the third all cause the medial, yeah? So know that the medial longitudinal fasciculus is the connection between the sixth and third nuclei. Know the PPRF is the start of your lateral gaze movement, and know that if we have a problem with the medial longitudinal fasciculus, we get what's called internuclear ophthalmoplegia, which is where one eye, the lateral rectus can move, but the medial rectus doesn't move because there's no connection with the third nerve. Make sense? Cool. That's seen in diabetes and stroke. Reflexes, extraocular reflexes. Know your accommodation reflex, which is convergence and meiosis. Know that your caloric reflexes, or if you turn left, it's going to do this and do that. Cool. The source of people don't worry about that. Orbit, don't really worry about that. Know one of these diagrams. I'd say know this diagram because it's from McMenamin's book, and McMenamin likes his book. So use that. Learn that. Because most of the diagrams you'll see, if you actually go through McMenamin's book, a lot of the diagrams in the exam are from his book. So I think what's sort of interesting, what's sort of good to know is how the lens works and how it constricts and dilates. So constriction of the pupil is due to constriction, is used to relaxation of the, sorry, I'm talking about the lens, sorry. So when the lens is circular, when you pull on it on the side, it becomes more flat and therefore diverges the light less, yeah? So it's for far away vision, it constricts. Now, yeah, and so constriction of the pupil is for faraway vision, etc. Constriction of the lens, sorry. Radial and circular muscles are for meiosis, and so the radial muscle, when that constricts, that's PSNS, that's third nerve. Constriction of circular muscle is third nerve. Radial muscle is SNS. Yeah, does that make sense? Because radial will pull it open. Lens, don't worry about it. Extraocular movements, you know all that. Blood supply of the orbit, just know it's ophthalmic artery. This is all just overkill. This is a diagram that I did for myself. I liked schematics. I don't know why, but I like, you draw that 5 or 10 times, and then you don't forget it. Like I could probably, I mean, I'm not going to say I could draw that now, but I could get pretty close to it. So, and I haven't done that for like a year and a half. So I think it's a good thing to sort of, if you have a pattern that you know, just do it 10 times, and you'll remember it. Don't worry about this. Arterial supply to the retina, important. So arterial supply to the retina is from the posterior ciliary arteries for everything, because that's the choroid. No. Sorry, say that again. Everything is done by the central retinal artery. So the central retinal artery comes out of here, and then you get the temporal and parietal branch, the temporal and nasal branches. They come out and supply everything in the eye. Now, what's this area called? Macula, yeah? And within there's the fovea and foveola. So the macula is, the macula is where your fine vision is. So you don't want arteries and shit in between that. So there's no arteries above that. So the central retinal artery, which runs on top of the retina, which is one of the reasons, it's actually, not that I want to get religious, but it's actually one of the pieces of evidence that scientists use to say that God doesn't exist, is because why would you create a eye that has arteries on top of the thing that you want to see? It's an odd way of designing it, if it were designed. I'm not going to comment. Does that make sense, though? Yeah. And so the cephalopod eye, or the eye of the squid and the octopus, is actually the right way around. It has the arteries on the back. Anyway, so the central retinal arteries go across here. They don't supply this because we don't want arteries in the way. That's supplied by the choroid, which is from the posterior ciliary arteries. Note that it's all still ophthalmic artery. Yeah, it's all still ophthalmic artery. So if your ophthalmic artery goes, your whole thing goes. It's just whether if your central retinal artery goes, you'll leave this bit because it's still supplied by the choroid. Know this. It was in our exam. Just learn, like you learn these. I think it was basically what's this, and it was like it was the pigment because it's the only brown thing. Like it wasn't the hardest question in the world, but learn it. Again, it's like 10 minutes of your time. You know, you're not going to lose anything. All right, guys. I know it's sort of going a bit quickly, but another important thing is knowing that the way photoreceptors work. I would read this. I've given you the notes. I would read this. Don't learn all of it. Just know that eyes work different to every other photosystem and every other receptor system in the body in the fact that they are constantly depolarized. And light hitting it polarizes it. Yeah? So they're constantly sending out messages, and when light hits it, they stop sending messages. So it's the opposite to every other system in the body in terms of the way that you sense. Don't worry about these. Know that if you do that question thing that I told you online, which hopefully someone will be able to put on 2019, Med 2019, so you can all have access to it. It's got questions that are like this, and it's like magnocellular and parvocellular nuclei cells and what they do. Don't worry about that. Like, know it for the exam, but I'm not going to go through it. Cranial nerve 5. Cranial nerve 5 has sensory and motor components. Motor are only in the V3, in the mandibular division. No pure SNS or CS or PSNS thing. They only are carried by them. So the fifth nerve doesn't have autonomic, it just carries autonomics. It carries, what autonomics does the cranial nerve 5 carry? 4 chocolates, because I've got a lot. We're going to run over time, by the way, I'm sorry. What else? So what does it carry? I want someone to just yell them out. Not Andrea, because he said 2 chocolates. What? There's no smell, by the way. What? Good, okay. Where does that come from? Goodbye. Does it? Does it? Facial. It's from the chorda tympani. It's from the superior, isn't it? Parotid, yeah. So I'll give you both chocolates. So parotid is from the inferior petrosal nerve. Yeah? Parotid's inferior petrosal nerve from glossopharyngeal. Yeah? Which is inferior salivatory nucleus. Superior salivatory nucleus goes through the chorda tympani and supplies the mucosa of the nose and also the as you said, submandibular ganglion. And that travels through the lingual nerve, yeah? And the other one travels through the what nerve? Okay, this is another one of my schematics that I drew, because why not? So lesser petrosal nerve of 9, glossopharyngeal, comes through, goes through the otic ganglion, joins the auriculotemporal nerve, goes to the parotid gland, as you were saying. The chorda tympani carries through the pterygotympanic fissure, goes through, joins the lingual nerve, and supplies the submandibular. Yeah? Cool. Good. So I think what would be nice is if you can learn all the autonomics, where they come from, where they go to. Yeah? So that's something you should know. Ciliary ganglion, it's all written there. I'm sure you sort of know it off by heart. But we've got SNS and PSNS. PSNS, as we've said, constricts the pupil and also accommodates. Accommodation is a PSNS thing because you don't want to look closely if you're running away from something. You want to look far away. You want to get everything in. Yeah? So PSNS is accommodation as well as constriction of the pupil. And the reason why we constrict when we look closely is because we don't want light coming in from the side. We only want one straight in front of us. And that's why we constrict. Dilation of the pupil is SNS and... yeah, cool. So second nerve, I think the only thing you really need to know is the infraorbital nerve goes through and supplies the lateral parts of the nose and up to the sort of all the maxillary area. If you want to know the other thing, so what parasympathetics and sympathetics run through V2, or are carried by V2. Remember, V2 doesn't have its own autonomics and sympathetics. So we have the greater, chocolate, come on. Come on, guys. Lacrimal gland, who said that? Yeah, good on you. Okay, sorry, I nearly just killed that person. So what nerves go to the lacrimal gland? How do they get there? Where do they start? Where do they finish? Sorry? Yeah, so where do they... Give me the path of the PSNS and SNS. Stunned silence. Okay. So they start off at the superior salivatory nucleus. They go through the seventh nerve. They go through the what's called the nervus intermedius, which is part of the seventh nerve. It goes through the geniculate ganglion, and then from there it forms the greater petrosal nerve. The greater petrosal nerve then joins the deep petrosal nerve. The deep petrosal nerve is part of the carotid plexus, is an SNS thing. So the deep petrosal nerve joins the greater petrosal nerve, and we get what's called the Vidian nerve, or the nerve of the Vidian canal, or nerve of the pterygoid canal. That pterygoid canal runs in and joins, goes into the the sphenopalatine fossa. In the sphenopalatine fossa, it joins the zygomatic nerve and joins the zygomatical temporal and zygomatical facial nerves. And I believe it's the zygomatical temporal nerve which carries those to the lacrimal gland. Okay? So we've got seventh nerve, greater petrosal nerve. That goes through the zygomatic nerve of V2 to the lacrimal duct. Everyone get that? Stunned silence means yes. Good. So this is the pterygopalatine fossa. Yeah, so I'll say it one more time. SNS comes from the carotid. It forms the deep petrosal nerve, and that joins the greater petrosal nerve. The greater petrosal nerve comes from the seventh nerve in the geniculate ganglion. It then forms the greater petrosal nerve. Greater petrosal nerve joins the deep petrosal nerve to form the Vidian nerve. That Vidian nerve goes into the sphenopalatine fossa. The sphenopalatine fossa is where V2 is, the mandibular nerve. Then with that, it joins the zygomatic nerves, which go into the orbit, supplies the lacrimal gland. Cool? Those two nerves, the deep petrosal nerve and greater petrosal nerve, they also supply the autonomics to the pharynx and the nose and stuff through through V2 as well. This is V3. As we already talked about, the lesser petrosal nerve carries the SNS fibres through the auriculotemporal nerve to the parotid. Lesser petrosal nerve, inferior salivatory nucleus because it's 9. Superior is 7 because it's higher up. 7 is higher than 9, as in higher up in the brainstem, not obviously a higher number. And then it carries the PSNS to the lingual nerve and to the submandibular glands. The SNS doesn't come from the brainstem, it comes from the things around the arteries, as someone mentioned. It goes through the MMA, the middle meningeal artery, goes to the optic. Don't worry about your SNS, really, because it's not that important if you think about it. It's not actually causing the glands to function, it's just stopping the glands from functioning. The PSNS is a lot more important. But just know the SNS is always coming from the cervical spine. Infratemporal fossa, don't worry about it, it's very complicated. Seventh nerve, as we already talked about. So this is a nice diagram that shows the greater superficial petrosal nerve coming off don't worry about just greater petrosal nerve, comes off, forms with the deep petrosal nerve, and forms the Vidian nerve. And the Vidian nerve goes into the sphenopalatine ganglion and joins the zygomatic nerves. And we've scared some people off. Cool. So going on to seventh nerve. Seventh nerve supplies all the muscles to the face, yeah, as well as we said, that SNS to the nose and lacrimal duct. It's important to note the difference between a facial nerve palsy and a cortical palsy, yeah? Everyone knows that cortical is forehead sparing, yeah? Cortical is forehead sparing because the top of the face is bilaterally innervated. Both sides of the motor cortex supply the top of the face. The bottom of the face is unilateral. That's why it'll affect that side. obviously, they all converge on one nerve. There's no crossing between the nerves themselves, the facial nerves themselves. So therefore, if you knock out the nerve, you knock out the entire face. Yeah? That's bread and butter. That's good stuff to know. Because when you're in ED and someone goes, oh, is this person, do we need to like take them to get them thrombolyzed, or do we just let them wait 2 days or a week and hopefully they get better? It's a big decision to make. Vestibular cochlear nerve, so it's into two divisions, vestibular and cochlear. Vestibular does vestibular, cochlear does sound. This is the internal acoustic meatus. These are the different nerves. I won't get into them. External ear. No, I know this. This is sort of a nice thing. Know this as well, because if you get an ear exam, I think it was 2 or 3 years ago, said, like, what is this area? And you had to know the helix, antihelix, tragus, antitragus, Simba and concha, yeah? Simba and concha. Cool. So learn that. I think, and you know, there's always that question about, oh, what artery is done if you go if you know, she gets something cold in her ear and then she faints. What is it? It's the auricular branch of the vagus, because vagus obviously does your vagal stimulation to your heart as well. And if you'll get a bradyarrhythmia quite quickly, and you can get some syncope, some cardiogenic syncope. Tympanic membrane. Know the tympanic membrane. Know what it's about. Know that you've got the cone of light. Which way is this cone of light facing? It's facing right. This is a right ear. Okay? So cone of light faces right. It's a right ear. Middle ear. Know that diagram. Because a couple of years ago it was an exam question, I believe. So know that diagram. Don't worry about these diagrams. These two are actually not too bad, this one and this one, because they just show what it looks like if you're looking laterally and what it looks like if you're looking medially. This is tensor tympani. What supplies tensor tympani? Which nerve? For a chocolate, quickly. Trigeminal, good. Right over your head, Kelvin. And what supplies stapedius? 7. Good. There's no chocolate in that. So don't be so keen. Yeah, and then the stapedius is actually, the reason why the stapes is that sort of shape is actually there's an artery that runs through it in embryological development. And that artery can sometimes actually be preserved, and the MMA isn't there. So the MMA, the middle meningeal artery, comes from the stapedial artery, and you actually don't have a foramen spinosum because it doesn't come from the external. It doesn't come from the maxillary artery. It comes from the there. Anyway, know this sort of thing. The endolymph, the perilymph. Know that one's potassium, one's more CSF, one's more extracellular fluid-like. Yeah. Endolymph is obviously more CSF-like. Perilymph is more extracellular fluid-like. Also note that, so what I don't think people understand certainly they did in my year, was the way sound actually works. And the way the cochlea actually produces sound. So the way it works is it's actually these things in here vibrating. And they each have a resonant frequency. You know how something has a resonant frequency. So these will have resonant frequencies. These resonant frequencies are really... I've got a picture of it somewhere. Yeah, so the resonant frequencies near the base are really quite high frequency. And the ones near the modiolus up here are very very low pitched, sorry. And so if you get a sound that is resonant here, it's going to be high pitched. If you get a sound that's resonant here, it's going to be low pitched. And the nerves that go to this know, oh, it's these things that are going to be resonant. That's why I'm getting a high pitched sound. Also know this. Know your depolarization, hyperpolarization. One way goes one way, the other goes the other. You've got your actin filaments, etc., etc. And it's the opening of the pores at the bottom and the top that cause your thing. Oh, okay, we're going to have a break in a second. Glossopharyngeal doesn't do very much. It supplies, so we'll go over the tongue a bit later. 10th nerve supplies a lot. Does all your innervation to all your PSNS above the pelvis. And it does taste as well, as we'll talk about. This is a nice picture of the neck. So we're going to do a bit of anatomy now. What is this? Come on, guys. Vagus nerve, good. So it's coming around the, what's this? Subclavian. So this is obviously the right side. It's going up the subclavian, turning into the recurrent laryngeal and entering the larynx. This is the thyroid cartilage. It's the cricocartilage. This is the cricothyroid muscle. This is the superficial external branch. So external branch of the superior laryngeal nerve, yeah, which supplies the cricothyroid. Internal branch of the superior laryngeal nerve, which supplies the mucosa of the larynx above the vocal cords. That's important. I'd know that. So, as in, you should know that. So, superior branch of the, vagus nerve has two laryngeal branches, superior and inferior. The inferior one is the recurrent. The superior one is this one up here. The superior one splits into two, the internal and external. External is muscular, it supplies the cricothyroid. Internal is sensory, it supplies the mucosa of the larynx above the vocal cords. This is the inferior one, it supplies all the muscles of the larynx apart from the cricothyroid. What muscle abducts the vocal cords? Posterior cricoarachnoids, yeah. And the posterior cricoarachnoids, if you lose one of them, you lose your ability to abduct the eye and you can get a stride or even death. 11th nerve supplies sternocleidomastoid and trapezius. Sternocleidomastoid, when it constricts, what does it do to the rotation of the other side? Good. So, other side. Trapezius is also 11. This is a common, it's in the superficial fascia and fat, so it's very regularly cut. This is a very nice dissection. Here we have, this is called, what's this point called? Does anyone know? Erb's point, yeah? It's called Erb's point. This is what artery? What nerve, sorry? For a chocolate, quickly. Greater auricular, who said that? Well done. Greater auricular nerve, yeah? This is what? This is what nerve? Superficial cervical, anterior cervical. These are what nerves, all coming down here? Supraclavicular. This is the accessory nerve, this one here. And this is the greater auricular nerve. The greater occipital nerve, sorry. Cool. Hypoglossal nerve does the tongue, yeah? Now, if you have a hypoglossal nerve injury, which way does the tongue go? Towards the lesion? Is that true? Okay. Okay, guys. I'm not going to go through all this. Okay, guys. Okay, so brainstem, we don't need to know this. Cranial nerve pulses. I'd know that. Learn that. That's going to be in your exam. Don't worry about these. Okay, spinal cord. So quickly, because we want to do some questions. And yeah. So know that this is DCML. This is corticospinal. This is spinocerebellar, posterior, anterior. This is spinothalamic, lateral, and medial. Yeah. And there's also a medial corticospinal. Yeah. And that's the one that doesn't. That's the one that doesn't cross. And you're right, it does go towards the lesion. I just had to think about it. So cranial nerve 12 does go towards the lesion because you lose your genioglossus on. So if I've got a left one, I lose my genioglossus on my left-hand side, so I can't protrude it. This one protrudes, and it protrudes the opposite way because genioglossus protrudes to the midline. It runs from the midline of the mandible out. So the muscles are angled like this, and so if they constrict, it's going to pull it that way. Cool. Vasculature. Do not worry too much about this. No anterior circulation and posterior circulation. Anterior circulation is all internal carotid, which all supplies the cerebrum. Yeah? Cerebellum and brainstem is all posterior circulation, which is from the vertebrals. Good. This is a nice diagram that shows basilar, circular willis, etc., etc. Know that if we have an anterior cerebral artery infarct, we're going to lose the medial part of the hemisphere, yeah? Medial part of the hemisphere is which part of S1 and M1? Lower limbs. So if you have a lower limb worse than upper limb, it's ACA. If you have a lateral worse than... If you have an upper limb worse than lower limb, you've probably got an MCA, and you might have associated cortical syndromes associated with it. PCA is mostly what? Visual cortex. Cool, that's just another diagram of that. There's some stroke syndromes. Meninges, no dura, falx, tentorium, know these things. This is a nice diagram. It's in Spanish, Portuguese? Don't know. Anyway, one of those two. Learn those things. Tentorium, cerebelli, falx, etc. Middle meningeal arteries. Guys. Thank you. So the veins run on the outside of the arteries. That's important to know. The veins run on the outside of the arteries in the middle meningeal. The nervous supply to the middle and anterior fossae is from V1, V2, V3, so trigeminal nerve. From the posterior fossa is cranial nerve 9 and 10, and 2 and 3, not 1. Why not 1? I don't know why I've written 1. Why not 1? Because 1 doesn't have a sensory component. It's all motor. Yeah, it's all the suboccipital nerve to the triangle, like the rectus capitis superior and inferior, and rectus capitis major and minor. Diploe, so this is the way that CSF is done. It's done through the arachnoid villi up and then out. Yeah. So you can have a communicating hydrocephalus. Guys, come on. You have a communicating hydrocephalus where you lose your ability to take this up, but you haven't got like a blockage of the Sylvian aqueduct. Sorry, the aqueduct of Sylvius, for example. But you do have you still have a hydrocephalus. Intracerebral hemorrhage. This is important. So I've got them written down there. You'll be able to read them in your own time. But I think what's most important to look at is the radiological pictures. So this is what shape? Lentiform, yeah? So why doesn't... So this is an epidural. Why doesn't epidural cause that? The sutures, good. Who said that? You can have a chocolate. That was an absolutely ridiculously poor throw. So it causes it because of the sutures. So the suture attacks here, and the dura attaches to the sutures. So the suture attacks here and here, so it's got nowhere to go. It just blows up in here. Traditionally, middle meningeal artery. Traditional arterial bleed. This is a subdural hemorrhage. So subdurals have that sort of crescentic shape, yeah? They lie between the dura and... Yeah, sorry, subdural. They lie between the dura and the brain, and the arachnoid and the pia, and they're usually venous. Yeah, and you get a transition from hyperdense to hypodense to isodense. Can you see it just there? Depending on how much time you've had, depending if it's acute, subacute, or chronic. Subarachnoid hemorrhages is always in the sulci. Yeah. Now, for a chocolate, if I was going to let's say, for instance, that you actually, let's say not for instance. Let's say you don't like me, which is probably possible, and you want to give me one of these three. You want to give me an epi, a sub, or a subarach. Yeah? Which one do you want to give me? Subarach. Subarachnoid is the worst. Yeah? It's actually a stroke. You actually lose circulation. You like me, okay? Think that's going to be a stretch of your imagination, but you like me. Which one are you going to give me? Come on, guys. Subdural? No. Subdural has an incredibly poor rate of recovery. Approximately like 50% die within like 6 months after that. I don't know the actual numbers. You can look it up. But subdurals are bad, yeah? Epidurals, a lot of people die, like a few people might die at the start, but once it's treated, it's really fine.
So, a question. Why would it give you a subarachnoid instead of subdural?
Because a subarachnoid is like a stroke. Like a subarachnoid is going to give you it's going to kill you if you don't catch it in time because you're going to have a stroke. And it's going to give you a lasting problem. It's more like the elderly people that have the subdurals, and the elderly people have a worse outcome because of that. It's a bit of a shitty question, I agree. But I think, not your question, my question. But I think that on the whole, you don't want something that's going to impact your vascular supply to the brain. And that's a subarachnoid hemorrhage is going to ruin that, yeah? After that, you don't want something that's going to have a worse impact on the brain and on your general future, which is a subdural. And then epidural is actually quite, I'm not going to say benign, but not bad. So this is some important neck stuff. And this is, I think if you know this slide, you're doing well. So all extrinsic and intrinsic is to the tongue, is to CN12, except for palaedoglossus, which is 10. All the palate is cranial nerve 10, except for TVP, which is V3. All the pharynx, except for stylopharyngeus, which is from the third pharyngeal arch, and therefore a cranial nerve 9 supply, is from the pharyngeal nerve, which is part of the vagus. All the larynx is, I've talked about this, the superior and inferior parts of the vagus, of the laryngeal nerves in the vagus. All the infrahyoids are ansa cervicalis, except for the thyrohyoid, which is just C1. The outliers are these, and you can learn them. Why is anterior body of gastric V3, posterior gastric 7 for one chocolate? Pharyngeal arches, good. Lots of people said that, so you don't get one. Oh, this guy seemed pissed off that you didn't get one, so you can have it. So because V3, so anterior body digastric is from the first pharyngeal arch, posterior body digastric is from the second pharyngeal arch, and therefore you get that. ECA, don't worry about it. So anyone got any questions? I'm going to give you a 5-minute break, and then we're going to start some questions. Like I think questions to you. Any questions about this? So there. It's not cortical veins. Enough time, because we don't have that much time left. Guys. So I just got, Monty wanted me to say something, which was that my quip about design and eyes and stuff would be only true if a being designed an eye that was, or humans or anything that was supposed to be perfect, and that if there was a design that wasn't supposed to be perfect, then it could still fit with that picture. Cool. Don't laugh. So the next thing I'm going to do is ask you some questions. There will be a chocolate for each one of these because I've got lots of chocolate left. Actually, it won't be a chocolate for any of these because there's 40 questions. So, temporalis muscle, innervated by what nerve? Okay. You. No, you, because you asked me about rodent. Okay, temporal branch of 7. Okay, cool. So, is that right or wrong? Temporal branch of 7, is that right or wrong? It's wrong, okay? So, now we're going to get there by first principles. So, temporalis, what type of muscle is that? It's skeletal, is it? Yes. No, it isn't skeletal. No, it's not skeletal. But more, don't worry, guys. So it doesn't matter if it's skeletal or branchial. What matters is what does it do? What does the temporalis do? It's a muscle of mastication. So if it's a muscle of mastication, what nerve is it going to be? Okay, which one of those comes from V3? Yeah, so the auriculotemporal nerve and the deep temporal nerve both come from V3, yeah? Now, auriculotemporal nerve is what? It's sensory and SNS to the, and PSNS to the parotid. Deep temporal nerve is the one that goes. He's out of chocolate. But, okay, so I'm still giving you chocolate. Okay, Peter has recently been in the motor vehicle accident. He has been airlifted to the Alfred. He's in ICU. Intensivist, who's like ICU doctor, goes and confirms that he's brain dead. He tells the family the EEG is flat and his ocular reflexes aren't active. He did not spontaneously respire when he was subjected to CO2 challenge. These are the things that you do when you're trying to require someone to be brain dead. But he saw the registrar, the mother saw the registrar testing his reflexes and plus reflexes bilaterally in his ankle, which nerve root is ankle reflex, by the way. S1, good. So bilaterally in his ankles and knees. What's knees? L3, 4, good. And as well as his brachioradialis, which is C5, C6. What would the intensivist do? Nothing. Who said that? You. Good. Okay, why?
Because due to the person.
Sorry, mate.
Because he's suffered injuries to the brain, there's no upper motor neuron inhibition going to the nerves that are causing the reflexes. And as a result, they're hyperreflexing. Is it normal?
No, it's not really the sort of answer I was looking for. I'll still give you. So the answer I'm looking for is because the spinal reflex is an arc within the spinal cord, and the spinal cord is the thing that's not being hurt here. It's the brain. Yeah? Cool. So, what's he suffering from? What's he suffering from? Subdural. Good. Here we go. Come on, guys. Okay, I'll pick out people. You. What's the answer? Okay. You, reclining. What's the answer? Yeah. Caudate. Yep. Why caudate? You need to be able to reason your answer, by the way.
It's sensory.
Caudate is sensory.
Oh, I don't know.
No. Okay. So caudate is part of the is part of a few systems, but mostly it's to do with motor. So it's a basal ganglia thing. Okay. So What's he got? What's he got? He's got right-sided weakness, and he's got right-sided facial. He's got right-sided facial, right-sided weakness, and right-sided sensory loss, yeah? So it's all on the right-hand side. Now, think about it. If it's in the spinal cord, then he's not going to have the facial stuff, yeah? If it's in the brainstem, he's most likely going to have cranial nerve symptoms, which are going to be contralateral. Remember? Because most of the innervation to the brainstem is contralateral. So, and he's got no hearing loss, he's got no other things, and we can't localize that in terms of the brainstem. So it's got to be above the brainstem, correct? Cool. Now, if it's above the brainstem, if it's in the cortex, yeah, it could be in the cortex, it could also be in the internal capsule. If it's in the cortex, is it the frontal cortex? No, because there's sensory findings, and sensory findings are in the parietal. So it's got to be in the internal capsule, which is where the sensory and motor combine. Does that make sense? Yes, good. Oh, sorry, muscle strength. Okay, so it's just a pure sensory finding. Doesn't make a difference. It's still...
Why is it not the thalamus?
Why is it not thalamus? Because a thalamic stroke... So, if you can't... So you'd have to really... It would be incredibly unlucky to get a thalamic stroke like this, purely because you'd have to get... you'd have to sort of get a... So the way the thalamus is done, you'd have to get corticobulbar... Sorry, not corticobulbar. You have to get bulbar and lower... Right and upper lower extremities and right side of the face all on one side. And they're sort of separated a bit, which is a bit unlikely. Second of all, an internal capsule is more common to happen. Like internal capsule.
But is it like VPL and BLM?
Yeah, so you go VPL and BLM, but then what's next to it?
Yeah.
So wouldn't you have... I don't know. There's a reason. I'll come back to that. I have to think about it. All right, guys. Okay, so who wants to have a go? You. No, you're not getting a go. All right, you taking your beanie off. Yeah, go.
Oculomotor palsy.
Yeah, so he's got an oculomotor palsy. Why do you say he's got an oculomotor palsy?
He has ptosis and
And what?
he has ptosis and
So ptosis could also come from Horner syndrome.
yeah, that's true. But he's also got
It's because like the thalamus has got lots of things around it as well. That would sort of... Yeah, go on.
his right eye's down and out.
Sorry?
Right eye.
Yeah, his right eye's down and out. Good. Okay, so that's a classic third nerve palsy. So, which one of those? Which side is his third nerve palsy on? It literally says right hand side. So, where's his lesion going to be? Which nerve, and where? So three, third nerve, yeah, because third nerves are common to cause a thing. So which one of those answers? There's letters there, by the way, guys. Ah, yeah. C. So why do you say C? Okay, so this is a PCA aneurysm, because PCA aneurysms commonly cause a third nerve palsy. PCA aneurysm. right-hand side of the nerve. The nerve doesn't cross once it's a nerve, so it's going to be the right PCA. Which one of those is the right PCA? B. So he's got clumsiness. He reveals motor weakness involving the left arm and leg. His speech is slurred and there is drooping of the lower face. Passive extension of the left arm. There is initial resistance followed by sudden release of tension, and extension is continued. Lesion affecting which of the brain structures is most likely cause of this? Come on, guys. Sorry? B, good. Yeah, it's internal capsule. Because if you think about it, none of those things, so what have we got? We've got insular, putamen, globus pallidus, and caudate head. None of those are really going to cause widespread things, upper and lower limb, including problems with speech. Okay. Yep. 34-year-old Syrian presents to your office with external ear infection. Oh, what a classic question. B, yeah, good. So, as we said, the vagal nerve does the posterior part of the internal auditory canal. If you get something in there, it can cause a vagal reflex. Vagal reflex, much like pressing both of your carotid bulbs or bodies at the same time, will cause a bradycardia, a relative bradycardia, which can cause cardiogenic syncope and collapse. Okay. So, what sort of thing do we think is going on? Okay, so who wants to go at this? Who wants chocolate? Who thinks they know the answer? Right, you in the glasses there. You got no idea? Okay. So yeah, he's got eye problems. So has anyone heard of nystagmus? So ophthalmoplegia, dementia, and ataxia. That's a triad of something. Does anyone know what that is? Yeah, it's Wernicke's. Wernicke's encephalopathy, yeah? And if you have a long-term problem, you can have Korsakoff syndrome. So Wernicke's encephalopathy is caused by what? Thiamine deficiency due to alcoholism most of the time. So if you've got a Wernicke's encephalopathy, what does it usually affect? Mammillary bodies. Which one of those are the mammillary bodies? Who said mammillary bodies, by the way? Oh, yeah, you get. Yeah, B. 43-year-old, oh, this is good, this is some lower limb. So symmetric knee reflexes, but the ankle jerk reflex is slightly diminished. Which one are we going for? Are we? Cool. Okay. 56-year-old woman is brought to the emergency department with sudden onset. What did we say? Yeah. A 56-year-old woman is brought to the emergency department with a sudden onset headache, partial loss of vision. She has 3-year history of AF. Physical examination has a visual field defect with this. What is happening? Sorry, yeah, posterior cerebral. So we've got a right homonymous hemianopia with macular sparing, which is a classical posterior cerebral artery infarct. 35-year-old male comes to your clinic, painful tongue sore. So you don't need to read all this. The important thing is the ulcer is located on the median sulcus, 1 centimetre anterior to the foramen cecum. The pain is carried by which nerve? Oh, there's more. Who wants to go? Who wants to go? No, you didn't have one. Who said that? You? Yeah, C. So it's C because it's anterior part of the tongue. So foramen cecum and median sulcus are the parts that line the 2/3, 1/3 boundary of the tongue. Foramen cecum is where the thyroid comes from, obviously. Comes down into the, that's where the thyroglossal canal lies. If it's anterior 2/3 of the tongue, so anterior 2/3 of the tongue, taste is facial, chorda tympani, good. Posterior 1/3 is glossopharyngeal. Somatic sensation, anterior 2/3 is lingual nerve, V3, mandibular division. Posterior 1/3 is glossopharyngeal for both, yeah? And epiglottis is 10, vagus. 54-year-old male undergoes evaluation for neurological symptoms. MRI scopes bilateral influx in the thalami. Oh, mate. Right here. So, yeah. Cool. Okay, so this is now talking about a person's getting chemo and they're getting vomiting, so vomiting associated with chemo. Anyone know what drug you give for chemo vomiting? Oh, that's strong, good. So how does that work? It's a 5-HT receptor antagonist, good. Now, where does the 5-HT receptors in the brain go? The chemoreceptor zone, which is where? The medulla, where? D, good, yeah. So it's in the obex of medulla, right at the bottom of the medulla in the calamus scriptorius. So 62-year-old woman comes to the physician with decreased vision over the 6 years, right-hand side, intermittent headaches, worse in the morning. Intermittent headaches worse in the morning, what's that a sign of? Raised intracranial pressure. Anything that's in the morning or with coughing, Valsalva movements, is intracranial hypertension. Because if you think about it, in the morning, you're lying down. You've been lying down all night, so you're having, your CSF isn't draining down. Yeah? So you've got more CSF in your brain or more pressure in your brain, yeah? And therefore, if you've got something else in there causing more pressure, like a tumour or anything else that causes intracranial hypertension, it's worse in the morning. Also worse when you cough, because of course that's Valsalva, increases intracranial pressure. So she had progressive difficulty, so she's probably got, so there we go, she's got a metastatic something. Right homonymous hemianopia. Both pupils constrict. The pupils appear to dilate. Patient's symptoms are most likely due to a left-sided lesion involving which of the following structures? Okay, what are we going with? LGN. Why? Is it? Then why would both pupils constrict? It's bilateral, yeah. So the light is immediately moved from the right eye. It appears to dilate. Does anyone know what that's called? Sorry? Yeah, good. So it's a relative afferent pupillary defect. So if it's a relevant, it's don't think, look, I think this question's a bit hard, so we won't go over it. So I'd say it's optic tract, but I don't think we should go over it. It's just too complicated. You're not going to get something like that in your exam. 34-year-old female presents to your office with, guys, moderate hearing loss, and she has noticed several months ago she has complaints of noise in her right ear and very disturbing. Physical examination shows right-side hearing loss and asymmetrical smile, decreased corneal reflex. Patient just intracranial mass located in which of the lesions? So, okay, this is a good question. So, right-sided hearing loss, what nerve? 8, yeah, good. Asymmetrical smile, what nerve? 7. Decreased corneal reflex. What is the afferent for a corneal reflex? 5 and 7, good. So, what's the common denominator for all those? 7 and 8, yeah? So, where is something where 7 and 8 both are? Between the cerebellum and the lateral pons. Yeah? Between the cerebellum and the lateral pons, because that's where the internal acoustic meatus is. Yes, that's where 7 and 8 go out. So what's a common thing that happens there? You get a vestibular schwannoma, yeah? Or an acoustic neuroma. But what you need to know is you need to sort of know, so we've got hearing loss, that's 8. We've got asymmetrical smile, that's 7. That's either 5 or 7. It's most likely 7, given we've got another 7 problem. Where is 7 and 8 likely to be? It's not between the peduncles. It's not in the paraphagia aspect. That's in the middle. It's not in the It's not over the hemispheric fissure. It's not in the diaphragm celli. That's anterior fossa. And it's not between the medulla and superior hemispheres, because we already know that 7 and 8 are pontine cranial nerves. So, yeah. 54-year-old man is brought to the emergency department with Wi-Fi 3 valves, difficulty speaking when asked about his onset of symptoms response. I'm weak this morning. Very frustrated. So I weak this morning. What does that mean? It means he's got a... Sorry? Yeah, Broca's aphasia. Where's Broca's area? B. Yeah? B. Good. Okay. Who wants to go to this? For a chocolate.
Facial.
Who said... One of you said it first. Yeah, facial. Why is it facial? Yeah, so nerve to the stapedius. Now, if I put if I did like a gunshot sound, would you be able to stop it with your stapedius? No, because the latency of the stapedial reaction is quite long. Yeah? So it's about, I think it's 70 milliseconds or even longer. So you wouldn't actually, you'd still hear that. But it's more good for if you've got a continuous loud sound like you're going to the movies or something else and it stops it down. Okay, which of the following corresponds to this cystic degeneration? Where is that? You that's going. What's the answer? Oh, she's just walked out. What's the answer? You can get a chocolate on your way out. It's just medial to the external capsule and the claustrum. Yeah, good. There you go. Enjoy. Cool. So the putamen. 59-year-old male comes to the physician because of diplopia and drooping... All right, guys. Diplopia and drooping right eyelid. Yeah, good. Who said that? That was a bit better. All right, as in the throw. 23-year-old Caucasian male, involuntary movements undergoing experimental radioisotope study, localized metabolic things brain. So abnormal metabolic activity in the caudate nucleus. Basically, which one's the caudate? A, good. There's no chocolate in that. Occlusion of the label X. What is the most likely result of? Walk upstairs, because what artery is that? ACA. Good. So that's lower leg motion. So that's lower leg motion, ACA. Yeah? So here's your carotid. here's your carotid coming up. This is through the petrous bone. Guys. This is through the petrous bone. This is going through cavernous sinus. This is carotid siphon. This is A1. This is ACOM. This is MCA. So this is all ICA. So this is the anterior circulation. This is anterior cerebral artery, which is lower limb motor. Yeah? Okay, so you don't really need to read anything. All you need to know is that where is this lesion? Where is this lesion? Come on, guys. So these are big. This is what? This is the cerebellum. These are big connections to the cerebellum. What are they? Middle peduncles, middle cerebellar peduncles. What is the part that connects with the middle cerebellar peduncles? This is pons. You can also note that it's pons because this is basilar bifurcation up here. So this is pons. Which nerve comes from this part of the pons, the anterior part of the pons, in the sort of actual pontine area as opposed to pontomedullary junction? Facial nerve, good. Go on, guys. So glossopharyngeal nerve, we've already talked about some of its functions. It does what? It does sensation and taste to the posterior third of the tongue. Yeah? Now, does it do taste and sensation to the anterior two-thirds of the tongue? No. That is facial. Good. Chorda tympani. General sensation to the tonsil lining. We don't know. Salivary secretion to the submandibular gland. Okay, we talked about that. What is the salivary to the submandibular gland? Facial, yeah, it's chorda tympani to lingual nerve. Protrusion of the tongue. Hypoglossal. So it's general sensation to the tonsil lining. Good. A patient recovering from traumatic injury in the face now finds himself unable to chew his food. His jaw deviates to the right side. Which nerve? Who said that? Great. So what nerve does motion of the jaw? So all the nerves that supply the muscles of mastication. So lateral deviation of the jaw is mostly lateral pterygoid muscle, and lateral pterygoid muscle is V3, as are all the muscles of mastication. V3 goes through which foramen? It goes through foramen ovale. Highly agitated 54-year-old man is brought to the emergency department by his family because he is unable to effectively communicate. Speaks clearly with conviction, but his sentences are incomprehensible. So what's he got? Yeah, he's got to wear Nickies. What supplies wear Nickies? Middle. Good, so C. 43-year-old presents with double vision walking down his sides. No other concerns. He eats a balanced diet. Trochlea, good. Going downstairs. Yep, good. 57-year-old man. So trochlea, superior oblique, you get intorsion, etc., etc. All these people didn't want to come to my lecture. 57-year-old man is brought to the emergency department following a generalised tonic-clonic seizure. His wife reports he has no history of seizures, but he's been complaining of intermittent headaches, memory loss and problems since the 2 weeks. Brain injury is solitary mass in the right temporal lobe. Again, we were talking about that. So right temporal lobe is what? Superior quadrigenopia. So it's good. Okay. Who wants chocolate? Yeah, you can get a cerebral. Good. Cerebral aqueduct. Cool. Because the cerebral aqueduct connects the third and fourth ventricles, yeah? So if you've got nothing in the fourth ventricle but everything in the third and above, it's going to be the aqueduct. 23-year-old Caucasian woman suffers an acute heart attack of optic neuritis. She has... Oh, actually, don't worry about that. Let's just done this. You don't need to know. Here we go. Yeah, C, good. Because it's ACA. ACA is upper thing. Okay, so this gives the sort of classical depiction of what's called a lucid interval. So a lucid interval is where you have some sort of trauma to the skull. You then get some sort of, you then have a period of like immediate concussion where you're like, what's going on? You're unconscious. Then after that, you have a period of lucidity where you're alive and you're awake and orientated, and then it gets worse again. Yeah? He's got a convex lens, so lenticular-shaped hemorrhage. What's that most likely due to? Middle meningeal. What artery does that come from? Maxillary. Good. Here we go. This is for like 2 chocolates because I need to get rid of them. Okay, last question. Stacey? I need to pick on you because you're one of the few people I know from the issue level. Go on. So fill in the gaps. Lower limb may be subdivided into regions based on position, action, and orientation. The musculature of the anterior region of the thigh is innervated by the femoral nerve, correct? Which is from which nerve roots? L2, L4. Come on, guys. It's via revision. Except for which muscle? No. So psoas, I mean, it doesn't really count. It's sort of a thing. But yeah. So pectineus, yeah? I believe. This is going from my memory. So pectineus, and pectineus is also done by which nerve? Obturator. Obturator is which? 2, 3, 4 again. But how is it different from femoral? Yeah, so anterior parts of anterior rami versus posterior parts of anterior rami. The 2 muscles that arise from the ASIS are, in the pink? Give me one. Okay, you can have a chocolate. You said sartorius. Oh, shit, that was a bad throw. Sartorius, and one more. Yeah, tensor fasciolata. Good. Okay, now, the 2 muscles that arise in tensor fasciolata, medial compartment is innervated by the obturator nerve, except for which muscle has a bit of something else apart from obturator? Adductor magnus. Good, you said that. And that is from tibial branch, yeah? It divides at the border of what? Abductor brevis. And 2 nerves are said to exit and then re-enter the pelvis. They are. Who said that? What was one of them? Yeah, but you've had chocolates. Okay, pudendal and one more. That gets a chocolate. Anyone? Andrea? Come on. Nerve to the obturator internus. Yeah? Nerve to the obturator internus. And what are their root values? So what's the root value of the pudendal? You should know that. S234, good. What's the one for the obturator internus? Yeah, L512, good. And I'm being kicked off. Cool.